next question is strategies for refractory disease. Certainly clinical trials are important as for providing options for patients. There are several up and coming and exciting trial options for patients. There are studies developing RAF inhibitors that are targeting patients with NRAS mutations. There are studies in patients with BRAF as well as atypical BRAF mutations targeting with new agents with these BRAF mutations as well as resistant BRAF mutations. And what's exciting about that space is that the trials are also targeting central nervous system involvement because the agents have good brain penetration. Also, there's a recent publication of data suggesting that lenvatinib is very promising in the second-line setting for patients with refractory disease or resistant disease that develops. While first-line study was negative for pembrolizumab lenvatinib versus pembrolizumab, we have had meaningful clinical responses in patients with progressing disease who then continue anti-PD-1 therapy with lenvatinib. Also, many patients are likely to be very excited about FDA approval in the coming months with TIL therapy, tumor-infiltrating lymphocyte therapy. This is expected to occur late in 2023 with the company Iovance, which has a review in front of the FDA. This is going to be quite a while before it's available in Canada. There's a first-line study being started to look at the role of TIL therapy plus anti-PD-1 therapy compared to anti-PD-1 therapy alone. Disappointing element of that is the patient has to choose between that study versus combination ipilimumab and nivolumab. But there may be a role for TIL in the first-line setting. And then we'll see what happens in the future in terms of whether Health Canada approves TIL therapy in the second-line setting based on the data that's available that's currently being reviewed by the FDA. Other strategies, of course, in patients with refractory disease is to really, I think one important thing that you should consider is to actually make sure the patient has truly refractory disease. We've had several examples of patients who have had evidence of disease progression after combination ipilimumab, nivolumab. They receive a lot of immune suppression due to toxicity, and then have progression of disease even, a couple of months after into their therapy. And I think in some instances, patients will have immune sensitive disease that is progressing after immunotherapy, but some of the reasons they're progressing are that they haven't received that much immunotherapy, or they've received immune suppressive therapy, and re-challenging these patients with single agent anti-PD-1 may be what is needed for these patients. That is also a mechanism to explain why some of the promising data in patients in the second line setting with other agents end up being less exciting in the first line setting because maybe those patients actually didn't have anti-PD-1 refractory disease. So really focusing on whether they have anti-PD-1 refractory disease, I think, is important.